Hi, Dr. Armstrong.
Hey, Darryl, thanks for having me back.
We're happy to have you back, happy to have you as part of our faculty. Today, we're going to talk about something that I find incredibly seductive, the idea of liquid biopsies. I mean, what could be sweeter than that? You know, something you don't have to dig into anybody's body for, and yet get a whole world of information. So let's learn the truth about that. Why don't you just remind our audience what you do and where you do it, and then tell us, what a liquid biopsy actually
Okay.
refers to.
Yeah, so Darryl, I'm a medical oncologist here at Duke University. I'm the director of research for our Center for Prostate and Urologic Cancers. And a lot of my research is actually focused on the liquid biopsy, and I can explain why I've chosen to go down that route. And, probably just to start us off, nothing probably stokes more fear in a man than having to go through a prostate biopsy. And so hearing about an alternative manner of getting information about the cancer through a blood test can be very attractive. And I take care as a medical oncologist of men with much more advanced disease, typically disease that may have relapsed despite surgery or radiation where the cancer has spread. And we use liquid biopsy nowadays as standard of care to inform on the many, lengthy menu of treatment options facing men with more advanced prostate cancer. It's a lengthy menu, and some of our menu options actually require a kind of a biopsy, either liquid or a solid biopsy, to inform that treatment decision to find molecular or genetic alterations that are very individualized, personalized for that patient. And there's a number of studies now showing the clinical utility or benefits of a liquid biopsy to open that door for that patient.
So I'm already just a teeny bit confused. Is this something that you would offer up to anybody off the street, or do they have to be diagnosed with prostate cancer first?
Yeah, let's start off with some clarifications. Some people are using a term liquid biopsy as a way of screening a patient who's not known to have cancer for a cancer diagnosis. That's not actually what we're going to spend most of our time talking about today, because those kind of liquid biopsy tests for screening have not yet been validated and are not yet widespread and are not yet recommended. But the idea behind those kind of tests, which are under study right now, are to take try to improve upon things like PSA screening or colonoscopies or breast cancer mammography, and find a blood test where the genetics can be detected in the plasma or through snippets of mutations or alterations in the DNA code that may have a cancer signature. And that could tell you if you have cancer versus whether you don't. And it might even pinpoint the site of the cancer, such as prostate cancer, for further workup. We're not at the point yet where those are being commercially laid out. Companies have been developed around certain approaches around epigenetic signatures in the blood, like GRAIL. What I'm talking about is actually much more further along, and it's using liquid biopsies, such as mutated DNA in the plasma or blood of patients that have known cancer, where they are looking for treatment options where that liquid biopsy could help guide them. So that's in a more advanced disease setting. And that's generally what we do nowadays in the clinic routinely.
So those tests that say we'll find 17 cancers, just prick your finger and send it in by mail, those are not really useful, especially I
don't want to say they're not useful, but what I would say is the large-scale studies to validate their usefulness and sensitivity, specificity, their ability to pick up cancer early and then intercept that cancer before it becomes aggressive, those haven't been done yet. But those are ongoing. There's been huge investments in the United Kingdom and in the United States, huge investments by companies to develop these liquid biopsy approaches for early cancer screening and diagnosis. Some of these are pan cancer. So there's a blood test, that could pick up whether a patient might have cancer and then kind of further identify what type of cancer. And that might then inform more tests like a regular biopsy or a colonoscopy to see whether it's correct and to verify, and then decide on surgery or radiation or medical therapy if that's indicated. We're probably still 5 or 10 years away from that kind of approach. And I'm very hopeful, obviously, that that will pan out, because many cancers don't have a test like the PSA. Pancreatic cancer, for example, there's no good screening test for that, but it's a really aggressive cancer that takes many lives, and we need early detection for many of these cancers. Kidney cancer is another example of a cancer that doesn't have great screening. Prostate cancer does have good screening already. So in a way, you can think about the PSA test as a form of liquid biopsy. It's very specific to the prostate organ and prostate cancer. It's certainly not as sexy as an epigenetic signature in the DNA of the blood, but it's a pretty good test, and it's the best we have right now, and even in 2021, for picking up prostate cancer early.
So maybe a real world example or two of when you would start talking to a patient, one of your patients, about liquid biopsies and what you're actually saying to them.
So many of our therapies in the advanced setting, let's say I have a patient with metastatic prostate cancer, when they're exploring their options such as hormonal therapy, chemotherapy, some of these newer hormonal pills, we don't actually need a liquid biopsy to make some of those decisions. We can use those drugs broadly per their FDA label, per the national guidelines like NCCN. The way those studies were conducted is in a broad group of patients, irrespective of that patient's genetic code or their tumor's genetic code. But then as we get into more advanced disease settings where the cancer has now developed resistance to those hormonal therapies, we call that castration or hormone resistance. We now have the approval of life-prolonging drugs, very effective drugs that only work in a small subset of men. The most commonly used drug would be something like olaparib, which is a PARP inhibitor. It goes by the trade name Lynparza. This drug works really well to extend life in about 20% of men with hormone-resistant prostate cancer, particularly those men that harbor a mutation in DNA repair genes like the BRCA2 gene or BRCA1 or ATM. And about 20% of men have that. And the only way to pick up that mutation would be through a blood test or a tumor biopsy where you've stuck a needle into the tumor to get it. But the liquid biopsy is a non-invasive test that can accurately pick up those alterations to help guide that therapy that could be life extending. Another example is a drug called pembrolizumab or Keytruda, which has a broad FDA approval as an immune therapy, even in prostate cancer, for the 3 to 6% of men in this more advanced setting that have what's called microsatellite instability or MSI high prostate cancer. Microsatellite instability is caused by errors in the DNA code that kind of pile up, and you can detect that either with a liquid or a solid biopsy. You tend to pick that up more in colon cancer, so you might have heard of it in that setting. Lynch syndrome is the hereditary form of that. But in prostate cancer, about 3 to 6% of men have it as well, and it can be familial or it could be just a random alteration that happened. And that is actionable. When you find that, it can lead to a therapy that has a dramatic effect on that patient's prognosis. I've had patients actually with metastatic prostate cancer that has melted away, where they've obtained a complete remission from the pembrolizumab, and that's been reported in the literature as well. And it's like winning the jackpot when you find something like that. And if you don't look for it, you won't find it. So it is now recommended in national, international guidelines to do genetic testing, both blood testing and tumor testing. The tumor testing can either be on samples that are archival, meaning they're old samples collected and sitting in a pathology warehouse somewhere, or they could be a contemporary liquid biopsy where you're simply drawing the blood, finding those mutations in the tumor DNA that's circulating, sequencing those and getting the results back in just a few weeks. So there's two main FDA approved liquid biopsy tests that can be used in men with prostate cancer. There's the Foundation Liquid Test and the Garden 360 test. There's also many academic platforms where they're homegrown, CLIA approved, validated platforms that can also be helpful. So one of these platforms can be very helpful to use to guide therapy. I see a lot of community doctors now ordering them, but I also see a lot of patients coming to me at a big academic medical center looking for trials, looking for options where they haven't had this test done, even though it's recommended by all guidelines now.
So do you find patients who are just newly diagnosed but somehow savvy to these two opportunities coming in saying, run my blood through whatever foundation
Mm-hmm.
or gradient and
Yeah,
let's.
newly diagnosed men, it can be impactful still to do the test, and it may not change your initial management, but it can set the stage for future treatment should their cancer progress. But it can also inform on whether that man has a hereditary form of cancer. So the liquid biopsy, not only can it help guide treatment in the future or in the present, but it can also tell you whether you may have inherited a form of cancer from a mom or a dad, and whether you could then pass that on to your children or share those genes with your siblings. So any first, second degree, third degree relatives may harbor those same mutations. And so it can have a dramatic and domino effect on family risk, family counseling. The BRCA2 gene is called the breast cancer associated gene 2, but it is not just a breast cancer gene. It gets that kind of name because that's how it was discovered. And it's also an ovarian cancer gene, but it's also a prostate cancer gene and a pancreatic cancer gene and a melanoma gene. So it's a cancer gene. When you inherit that, you're at risk for multiple cancer types. And there's a 50% chance of passing that on if you inherit that to your children or sharing that with your siblings. So finding that could help open the door to treatments like these PARP inhibitors, but it also might help your children get early detection and have their cancers picked up early before it can be aggressive.
It can also excite anxiety and, a whole worrisome constellation of emotions for some
Yeah,
people.
that's why we do recommend genetic counseling to go along with this testing. It shouldn't just be done in a vacuum. It shouldn't be done with education and with a lot of support, especially for family members. And family members should make their own decision for themselves about whether they wish to know this knowledge. Sometimes, people don't want to know this information, but because we can actually act on this information and sometimes save lives, many people do want to know this information.
Yeah. So you've got one test that sort of channels out 20% of people that are good for PARP inhibitors. You got
Yep.
another test that'll do, identify 3 to 6% more or
Mhm.
less for Keytruda and, anything similar to
Yep.
Keytruda, I guess.
What else?
Yeah. What else?
Yeah. So the genome of men with prostate cancer is very diverse. So if I have 100 guys with prostate cancer, all advanced with metastatic disease, I do get 100 different answers. So not all the same patients have the same alterations. And, like I mentioned, about 25% can really have this very actionable finding. There are other alterations that could be actionable for the future. There are studies that are ongoing looking at new genes and using new drugs that can intercept the cancer in different ways. For example, there's a gene called PTEN, and when that gene is lost, it actually can confer sensitivity to a new class of drugs that is under research study right now. So AKT inhibitors would be that class of drugs. That doesn't mean that they will be successful. We're hopeful that these will be successful, that they will pan out and become approved and extend life. But what I would say the liquid biopsy can do, in addition to these standard of care things, is possibly open the door to clinical trials of new drugs. We're always testing, as part of research, new therapies that can work, differentially in patients that have these alterations. Some of these alterations create an Achilles heel where the cancer's vulnerability can be exploited with new therapies. And we're always testing these new therapies or combinations of therapies for these patients. So if you know what your genetic code and makeup of your cancer is, that knowledge can be very powerful, can help open up a clinical trial, usually at a very large academic center, a comprehensive cancer center, or at a site that does a lot of research. Clinicaltrials.gov is a great resource for patients. If you have that mutation, you can put that search code in, and it sometimes will tell you what trials are in your area that may open the door. Now, clinical trials are experiments. They don't have proof of them working until they're successfully proven. There's a lot of other precision medicine approaches that we do, like the PSMA PET scans. But the molecular profiling that we do through liquid biopsy helps open several doors. Liquid biopsy can also apply to other things besides DNA, by the way. I've spent the last 5 or 10 years now working on other forms of liquid biopsy, one of which you may have heard of called the ARV7 test. It's a circulating tumor cell test where you've characterized that male hormone receptor called the androgen receptor. We call it AR. And AR can undergo mutations and variations at the RNA level that confer resistance to our commonly used hormonal drugs. So men that have a liquid biopsy that says they're ARV7 positive are very unlikely to benefit from these hormonal drugs we use. And they may be better suited with these newer therapies like docetaxel or cabazitaxel or radium or PSMA lutetium, or some of these new precision tests like the DNA repair defects and PARP inhibitors. So it helps to kind of triage a situation and explain a situation better. As you're facing a long menu, you might give more education to that patient to make a more informed choice.
So when we hear the phrase biopsy, it sounds more like a binary discussion. You either have cancer or you don't. And then like for prostate biopsy, the primary, you either describe an Epstein group or a Gleason score and such. But it sounds like a liquid biopsy is a multitude of answers from one drop of blood.
That's right. It can mean many things. So in the context I'm talking about, in patients that already know they have cancer, and that cancer is becoming resistant, hormone resistant, you're looking for answers for treatment. The biopsy is really getting the tumor DNA, sequencing it, finding the Achilles heel, linking that to a precision medicine, personalized choice that could benefit that patient. So the goal of the liquid biopsy is to optimize care, in the end. It's kind of helping with that treatment selection. But there are other contexts by which liquid biopsy could be useful, to avoid a regular biopsy or for diagnosis. The earlier discussion that we started off with, some companies are developing very sensitive instruments, blood tests, where they might be able to pick up cancer cells even before they've left the prostate or the organ in which they start, where cancer could be picked up when a patient doesn't even know it. That's screening. But right now, the way that we do it in the clinic is more to inform treatment choice.
No, that's super. Well, why in the support groups that we had running before COVID and now online, sometimes people ask, why aren't you looking at my semen? Why are you looking at my blood? The semen seems to be more relevant to a prostate.
Well, as a medical oncologist, most of the patients that I see don't have a prostate anymore. They don't make any semen. So it wouldn't be very helpful anymore. Most of the patients that have had relapse they've had either radical prostatectomy or radiation, so there's no semen production, or the cancer has already spread beyond the prostate, where you're trying to characterize those little malignant clones, those tumor cells that have spread now beyond the prostate. And they would not be detectable in the semen because they're in the bones or they're in the lymph nodes or they're in a distant organ. So that DNA is shed into the bloodstream and you can pick it up that way. But people have looked at urine and expressed urine, like prostate massaged urine, and can find genetic fingerprints in the urine for early detection. The PCA3 test, for example, is sometimes used to help identify more aggressive prostate cancer using expressed prostate massage urine, but largely we're not using that in the more advanced settings because the prostate's just not there or as relevant anymore.
Right. And what about other excretions, like nasal tests that we're sort of getting used to, and perhaps like stool, like the Cologuard tests for colon
Mhm.
cancer? I mean, and anything else
Well,
we sort of,
it's an
yeah.
interesting question. Right now these are research questions. There's a lot of information that can be gathered that way. I mean, certainly when we are looking at germline testing, what is the DNA makeup of you as a human being? You can get that DNA through a blood test, your white blood cells or your normal DNA. You can also do a spit test or a swab of your cheek. And that DNA is just your normal DNA. And we can do germline testing using those simple kits where you spit in a tube and send it off, and you get your results back in 3 weeks. That's not technically a liquid biopsy because you're not assessing the tumor, you're assessing the person. It is a form of DNA sequencing, which is important. That's called the germline or the normal DNA. Stool is an interesting question you ask about. There's been some very interesting studies over the past 10 years about the microbiome. The microbiome, are the bacteria that live on us or within us that are normal, not pathogenic bacteria. They're all just sitting there. They're often determined based on what you eat and your lifestyle. Some people have a certain collection of microbes that live on them, while others have different ones, depending on whether you're a vegetarian or a meat eater, and how much you exercise and how much sugar you eat, where you live in the world. And prostate patients, actually, a recent study we just reviewed at our own institution's journal club was a very nice study that came out of the UK and Switzerland that showed that men who have hormone resistant prostate cancer have a very different microbiome in their stool than men with hormone sensitive, untreated prostate cancer, and that those bacteria that survive that hormone state, that hormone deprived state, can manufacture testosterone and contribute to hormone resistance, which is just kind of a wild thought that the bacteria that live on you or in you might actually determine your survival. And we've learned that from other cancers, that the immune therapies that we give commonly to other cancers like melanoma, bladder, lung, kidney cancers, your microbiome actually determines your immune response to those immune checkpoint inhibitors and your survival. And people are now working on, trying to understand which species of bacteria are most critical to have the best response and how to get that into more patients, either through what's called a fecal transplant or through some sort of probiotic slurry or a pill, or to wipe the bad bacteria out with antibiotics, or what kind of foods to give a person that might select for the good bacteria. We call those prebiotics. So that's a fascinating question. I would say we're just in our infancy of thinking about how to exploit that therapeutically right now.
Yeah, and I wish I prepared myself around fecal transplants and such.
We do it in medicine. If you come down with what's called C. diff infection because you got antibiotics and got severe diarrhea caused by that super bacteria, Clostridium difficile, and if that can't be cured with antibiotics, we do fecal transplants to get rid of it. So you can transform somebody's microbiome by wiping out the normal bacteria and replacing it with healthy bacteria, and that cures that disease.
Yeah.
People are now doing that in cancer. So they're taking fecal transplants from surviving cancer patients who had a great response to immune therapy and giving it to patients who need a boost in their immune system to overcome their cancer.
Man, I could just imagine the politics around that. Yeah.
People are willing to do basically anything it takes to survive.
Yeah, it raises the idea that we think of ourselves as living alone, but we have dust mites on our body or whatever, all these
Mhm.
little parasite kind of things, bacteria of all sorts living
Yeah,
inside of
this
us.
this teaches
Yeah,
us that we are in symbiosis with our planet and the things that live on us or in us, and that
yeah,
what we do to ourselves not just affects us, but the microbes that live in us, and that they sometimes can take revenge on us for being bad.
yeah. As we close, yeah, and be nice to your bacteria.
Be nice to your bacteria; they'll be nice back.
As we close this down, what can you the process of liquid biopsy or of excretions teach us about when to stop therapies?
That's a great question, and many liquid biopsy companies are working on monitoring tools. So right now, as a medical oncologist, if I'm using a new drug, let's say docetaxel or enzalutamide or abiraterone, usually I know if it's working. If the patient's PSA drops, if their scans show improvement, if the patient feels better, that's all very reassuring. But sometimes there can be some confusing things when you might see a new lesion, you're not sure they're really progressing, or if a patient's having some symptoms, but you're not sure if it's cancer related, or if there's a disconnect between imaging and the PSA test. And a monitoring tool where it gets at the number of circulating tumor cell fragments or the number of circulating tumor cells or the morphology or the what we call phenotype of those cells changes over time. We know that some prostate cancer cells shift from typical prostate cancer into more aggressive variants like neuroendocrine prostate cancer. If you could pick that up with a liquid biopsy, that might help guide therapy and get you to stop an ineffective therapy early and move on to something more effective. This year, we actually published on a liquid biopsy test that could tell a patient if they had neuroendocrine prostate cancer without having to stick a needle into an organ or get a traditional biopsy. So that could be helpful because we would design their treatment plan very differently if we knew we had that.
No, that's super. Anything you're excited about over the next 3 to 5 years?
You know, the microbiome stuff is exciting, but in that, in a way, it's not really technically a liquid biopsy. I would just call that microbiome therapy or microbiome assessments. The liquid biopsy space, just to wrap that up, I think we are still working to understand the prostate cancer genome and the vulnerabilities to certain therapies. We're able to now classify many tumors into different buckets, where the vulnerabilities may be very different between 10 patients here and 10 patients there. Just getting information from the liquid biopsy can help identify those patients who might benefit from our experimental studies. And my hope is that these new treatments, which might include PSMA therapies, PARP inhibitors, immuno-oncology products, bispecific antibodies, CAR T cells, all sorts of therapies may work differently depending on your liquid biopsy results. And incorporating that into our trials and also into standard practice allows us to really better identify patients that would benefit.
Yeah, and you mentioned the CAR T thing, like as a bonus last question. Like these, I read of mRNA being used to sort of make CAR T more effective for prostate cancer, or at least for solid tumors. I'm not sure. I don't recall how it was worded. Can you tell us anything around that? Any thoughts?
Well, we don't have an approved CAR T cell for any solid tumor, so we're still a ways away. There's lots of things that the solid tumors like prostate cancer do to evade CAR T cells. They have very dense microenvironments where the cells just don't get in there. They secrete immune suppressive molecules or checkpoints that even though the CAR T cells might get there, they're shielded. So we might need combination approaches, and we might need some genetic editing of those T cells to kind of make them more supercharged so they can infiltrate tumors and maybe target different antigens. So we're still learning our way through the CAR T cell environment. I'm very hopeful that those kind of genetically engineered CAR T cells will have a more favorable effect than they have so far.
Well, when they do, we'll ask you back to explain it.
That would be
to
great.
us. Okay. Anything else you want patients to know about liquid biopsies?
Yeah, I would say as you take a lesson from this is just to ask your doctor, have I had my DNA sequenced? What is my hereditary risk? And could that be helpful to guide my therapy? Just asking your doctor that simple question. They may be so busy that they just hadn't had time to talk to you about that, but they're going to be happy to do that because it's actually recommended in all national guidelines. So just asking the question, you often will be offered that blood test.
Super. Thank you very much for speaking with us today. Thanks for the care that you give your patients and for the investigations and research that you do to advance the medical science that keeps us all alive and happy. So
Thank you, Darryl.
gratitude. Thank you. Hope to see you again.
You too.